back, everyone, to Einstein's Eyes. I'm here with a very special guest, Dr. Peter Hersh in northern New Jersey. Dr. Hersh is no stranger to Albert Einstein College of Medicine. John and I were students of his at Albert Einstein during our ophthalmology residency. To give you, again, to recap, I'm an oculoplastic surgeon and neuro-ophthalmologist in Anchorage, Alaska. Been here for 30 years.
I'm John Ditkoff. I've been in practice 30 years now. I do general ophthalmology specializing in cornea. I'm in northern New Jersey. And it's really an honor to have Dr. Hersh here. I mean, he's one of the reasons I became a cornea specialist in my early days. I even did my first laser vision correction at his center. I've referred many patients to him over the years. There were these tough cases that I was not comfortable with. So I'll let Carl introduce him more, and really looking forward to hearing about some topics.
Thank you, John. Dr. Hersh, Peter Hersh, is the founder and medical director of the Cornea Laser Eye Institute in New Jersey and the clinical professor of ophthalmology at Rutgers. Dr. Hersh led the landmark FDA trials that brought LASIK to the US in 1995 and later spearheaded the pivotal studies that won approval for corneal collagen cross-linking, transforming care for keratoconus and ectasia. He's written 4 textbooks, published more than 100 peer-reviewed papers, invented surgical instruments still in use today, trained thousands of eye surgeons worldwide, and we're just thrilled to dive into refractive surgery, cross-linking, keratoconus, and the future of corneal innovation with one of the field's true pioneers. I can say that honestly, Dr. Hersh, and thank you for joining us today. Let's just dive in. John and I will kind of go back and forth. Stop us at any time. Tell us about your origin story and your career arc. How did it get started? I know you're a Princeton graduate, Johns Hopkins School of Medicine, and then what happened?
Well, curiously, I first got interested in ophthalmology because we had a very good ophthalmology department at Hopkins, and I was originally going to go into retina. And that was my interest. I had been doing a bunch of research actually in angiogenesis back in the days when there was no such thing as vitreoretinal injections, and they were just starting to look at different growth factors. And that brought me to some research actually using growth factors for corneal healing. And that's kind of what got me into cornea. We were throwing all sorts of things, be it things like VEGF and the like, onto corneas to see what would make a cornea heal better. And one of the types of models that we used was an RK model. What we did was measure the burst strength of RKs after healing in a rabbit and after we used a variety of topical growth factors. So that's kind of what brought me into cornea and refractive surgery, is actually looking at wound healing and how we could modify it. Curiously enough, when I was up in Boston, they were just starting with the excimer laser, and I was working with Carmen Pliafito and Roger Steiner there on some of the laser work, and that's what got me into the first clinical trials of the excimer laser. But they needed and wanted a site down here in New York, and hence through Ron Bird, I came down to Einstein, and we started a clinical trial center using the excimer lasers. So some of the very first lasers were actually performed at Montefiore. This is going back, I think we did our first one in about 1992. And it was really the support of Ron Bird that let all of this be actualized. And there were any number of Einstein students who would work with us, students and residents. And in those days, the laser was going kind of 24/7, doing a variety of experimental work, things that we would never do today. But we'd want to see how many clicks of the laser does it take to perforate the cornea. So rather than the kinds of LASIK we see today, where we're taking 50 microns or so, we went down 500, 600 microns. See, hey, maybe we could do a lamellar keratoplasty with the excimer. So those were really the fun, good old days when all of this new technology was first being brought to the fore, and that's kind of got me where I am today.
Yeah, I remember those days. I remember
We were there in
walking,
92.
yeah, into
Yeah.
Montefiore because we were there, John. And
Yeah.
I remember seeing you, Peter, with your students, who I think some medical students, including residents, and that monstrous machine. And I didn't really understand it because I was the fracture guy. I was working with Simeon Lauer and the oral surgeons and doing facial fractures. Springboard off of what you said, cross-linking. You were really instrumental in igniting that area. Can you talk a bit about cross-linking and keratoconus management, how that all fits in?
Sure. When we look at keratoconus, in talking to patients, describe three avenues of treatment. Well, what do we want to do? Keratoconus is a progressive disease. It's really a unique disease because it is secondary to biomechanical perturbation of the cornea. I always explain it to patients. It's like having a thin spot in a tire or balloon. The cornea starts to bulge out and the optics start to scatter light, and that diminishes your vision. Cross-linking was first started in Dresden, Germany by a group led by Theo Seiler. And it was really energized by biorefractive surgery. As I said, I kind of got into this looking at wound healing after refractive surgery. What was back in the late 80s, early 90s, at the beginning of LASIK, that people started noticing corneal ectasia. And Theo Seiler's group started working both in the laboratory and then with patients on corneal cross-linking for keratoconus. What cross-linking essentially does, it uses the combination of riboflavin, which is a photoactive flavonoid, and ultraviolet light at 365 nanometers, which is the peak absorption spectrum of the riboflavin. This causes the release of oxygen-free radicals, a variety of hydroxyl radicals, and activated riboflavin, which militate the formation of crosslinks in the cornea. The crosslinks likely be between either collagen moieties and the glycosaminic glycans, or even within the gags themselves. So the bottom line is cross-linking causes the cornea to become stronger and mitigates the progression of keratoconus and is about 93% effective, as we found in the US clinical trial. So this really is the answer of the first problem with keratoconus, which is progression, and really revolutionized our treatment of the keratoconus patient.
I used to see patients 20, 30 years ago, and there was nothing really we could offer them. We would just say, we're going to do this, we're going to do this, we're going to do this. But if your disease progresses, you're going to need a transplant. So, I mean, like what Peter was going to allude to was we would do things to improve their vision. What we had to deal with the situation that we had. So if they had an irregular cornea, we might fit them with a special contact lens, do things like that, and just hope it didn't progress. So continue.
I clearly remember from my early days at Montefiore, a medical student with keratoconus. Really, the only thing we could do then was corneal transplant or contact lens. And he had a successful transplant and has done well thereafter. But right now we're able to use cross-linking and really prevent the rapid progression, especially if we diagnose it early
Yeah,
in the disease process in younger kids.
it's miraculous. Yeah,
Yeah.
really.
So let's just switch gears for a second and talk about refractive and corneal innovation, if we could. Smile has chipped away at LASIK volumes. I'm guessing. I'm not a LASIK surgeon. This is what I've read. Can you talk about LASIK, Smile, conductive keratoplasty, and how that fits into your practice?
Sure. Well, obviously, the mainstay of refractive surgery is LASIK. I would say about 75% of cases done today are LASIK, and the results and safety have improved markedly since the early days. One of the most important innovations and changes that we've had over the years is a much better understanding of corneal optics. In the early days, the optical zones on LASIK and PRK were quite small, and they left an edge, so to speak. So there could be a lot of spherical aberration, causing side effects of glare, halo, monocular diplopia, and things like that. And this was understood more in greater depth over the years. In fact, back when I was at Einstein, I worked with Professor Warren Blaker, who was an adjunct there, and Warren and I and others worked on really spherical aberration of the cornea after LASIK. We had nothing to do with the innovations that have ever since ameliorated the problem, but that is one of the ways that the procedure has gotten much better. And then, indeed, with the introduction of the femtosecond laser to make the LASIK flap, I think it made the procedure much safer and more reliable. Intrastromal lenticular extraction, or SMILE, is also gaining in popularity. It may have an advantage that you don't have a LASIK flap. It's still unclear whether it really is a procedure that completely avoids any problem with corneal ectasia. But getting to corneal ectasia, that probably was a problem in misidentification of form-fruits keratoconus patients early on. And these are patients who were predisposed to KC, where the LASIK then brought it out, rather than the LASIK per se being the proximate cause of the ectasia and the keratoconus afterwards. Now, one of the refractive problems that people are very interested in today is presbyopia. There's yet to be a good solution. And most of the good solutions today really are in the realm of cataract surgery with the new multifocal lenses, the extended depth of field lenses. That is something that is, I think, having excellent results. People have tried inlays, such as the AccuFocus inlay and the raindrop, but using artificial materials in these inlays really did not have a great reaction. A lot of these patients had haze and scarring. One of the interesting things that we will be starting trials in the US is the Allotex procedure, which is a microlenticule made from allogeneic preserved tissue to help the correction of presbyopia. So that's something that's very interesting on the horizon.
John, you did LASIK in the past, right?
Yeah, for many years. I do much more PRK now, yeah, for many years. I did radiokeratotomy in 1994.
Are you moving to a PRK because of safety reasons or outcome reasons, do you find?
Yes, I got to a point in my career where I really felt the results were comparable, and I did feel that in the overall patient population, it was probably a little bit safer. And now with better medications and pre-op counseling, I felt that the patients tolerated the procedure very well. So I really kind of went that direction. Nothing against LASIK. That's the direction I went.
In the new ChatGPT era, come about Sam Altman's company, it's been fascinating. AI is part of my life, my daily life, and I'm actually looking to create an LLM that's ophthalmology centric, and that's another topic which John and I will get to. AI, big data, and the cornea. Can you speak to that at all, Peter? Is that something relevant to your practice?
I think definitely. One of the things that people have been always interested in keratoconus per se is early detection. So advanced learning models, I think, are going to be able to take the increasing availability of topography, tomography, wavefront measurements, and be able to diagnose, so to speak, those patients who may develop keratoconus, those patients who shouldn't get refractive surgery because they are at greater risk of developing keratoconus. Indeed, I know there are cornea specialists out there now who are working with AI models for the early detection of keratoconus.
So in the early days, even now, my topographer would always give me this analysis, like high risk keratoconus, low risk, no keratoconus. I mean, to me, I actually laugh about it. I think that was the early version of AI.
Yes.
Yeah. So do you agree with that? I mean, is that an early version of AI for you, Peter?
Well, in a way, it is because the machine is
Yeah.
telling us and is analyzing the results for us. And as you get more sophisticated versions of
Yeah.
of outputs from topography and tomography machines, I think that AI will be able to develop more complex algorithms for early detection.
If I was a 17-year-old with keratoconus and I was hoping for perfect vision without glasses, what would you tell me? How would you guide me or advise me?
Well, number one, it's very difficult to get perfect vision without glasses in keratoconus. Next, you have to understand that from a medical point of view, the most important thing when you're diagnosed with keratoconus, especially if you're a teenager, is to get early cross-linking. Because if you're young, your keratoconus can progress quite rapidly. So I would seek cross-linking really ASAP. But remember this, probably the biggest myth in the keratoconic um, community is that cross-linking will improve your vision.
Right.
The goal of cross-linking is not to improve your vision, it is simply to keep you from getting worse. So that's very important to understand. But how do you get better vision? There are a lot of ways now that we are much better at it than we were in the past. The first are through sophisticated contact lenses. So there are, as you know, custom made, usually scleral lenses that can give patients with keratoconus, even rather um, advanced keratoconus, really excellent vision. And there are new surgical techniques that can indeed improve, um, as I say, the walk around vision, or the uncorrected vision. But it's very hard to give a keratoconic patient perfect uncorrected visual acuity because of the aberrant optics that they have.
Great.
What do you think about not really the frank keratoconic, but a form thrust, who now is getting cross-linking prior than some doctors are performing PRK? What do you think of that?
Well, I think that if one has form fruste keratoconus, or to step back,
Yeah.
let's look at some of the new technologies we have today. We have topography guided PRK, which, as you know, obviously takes the patient's topography map and will then guide the laser to flatten the steep areas and steepen the flat areas. So we are much better able to correct a patient with irregular astigmatism. I still would not recommend it
Yeah, that's
necessarily for patients with real keratoconus, but if a patient has very early potential form fruste keratoconus, especially if they're not in the age range of rapid advancement. So I wouldn't treat a patient in their teens. But
right.
if there's a 40-year-old with form fruste keratoconus who we know
Yeah.
has been stable, I think combining cross-linking with topography guided PRK is a reasonable approach.
Okay, yeah, that's helpful.
I have one final question. It is this. What do you think will be the biggest change we'll see, ophthalmology will see, by 2030 in refractive surgery and in the treatment of keratoconus?
I think how you were talking before with AI. I think AI will, number one, give us early detection and will also give us algorithms for improvement. We are currently working actually with CorneaGen on a project called CTAC, or corneal tissue addition keratoplasty for keratoconus. Actually, my co-developer, Stephen Greenstein, is a Einstein medical school graduate. And what we do with this is we use a femtosecond laser to shape intrastromal corneal inlays using preserved corneal tissue. And we've had excellent results with this to give many patients substantially improved visual acuity, both uncorrected vision and corrected visual acuity. And I imagine that in the future, we will be able to map corneas and potentially detail corneal shapes that we can then bring our entire armamentarium of tissue shaping, perhaps other techniques, to try to restore what you would think of as an optimal corneal curvature to give the best possible vision in keratoconus patients.
It would be nice to not have to do a full thickness transplant. I mean, that would be amazing in some of these people.
We have one of the innovators.
We could have taken one of those topics and talked for an hour.
I know.
But
Really.
you guys really did a good job. I was very impressed.
Yeah, we'll get you back on. I can't tell you how happy and thrilled John and I are to have
That was
you on the
very
channel.
It's a lot of fun. Thank you.
Yeah, so we're gonna do this again, but please like and subscribe, everyone. Share this. This was pearl after pearl, and we will see you guys on the next one. Thanks again, Dr. Hersh.
Thank you very much for having me. Great being here.